As soon as I walked into the visiting room and I saw her there, I knew she was a lot better. She ran to me, she hugged me, and her first words were like, "Mommy, why am I here? Why have you put me here?" And she didn't have any idea what was going on. And I explained to her, and then she would say things like, "Was there a war?" "No, there was no war." "How long have I been here? Decades? How old I am?" "No, you're only 15. At least she believed me. So by the end of that meeting, she felt a lot better, but she was completely despondent at the beginning of that meeting. And I could kind of understand why. One day you're in Costa Rica with your friends, and the next day you're in a psychiatric department. I talked to her psychiatrist afterwards, and I'm like, "She's a lot better." And he said, "I think she's depressed." That's such a weird thing to say, you know? She's not depressed, she's just upset. Wouldn't you be? So in her records, it said anxiety, depression. And so that became the explanation for her needing psychiatric medication. And he said, research shows that you need to be on Seroquel for 2 years to protect the brain. I didn't find any research that supported that. But at the time, I just listened to him.
Hi, I'm Dr. Josef Witt-Doerring. It's my pleasure to be joined today by Beth. Beth is going to be sharing a story about adverse reactions to Seroquel or quetiapine that occurred to her daughter that caused quite significant psychiatric problems, including catatonia. And so, Beth, thank you so much for agreeing to come on and share your daughter's story and your story.
Thank you.
Yeah. So I think a great place to start with all of these is really at the beginning. What was going on to have your daughter end up on Seroquel in the first place?
Well, truthfully, I believe she was misdiagnosed with a psychiatric illness and put on quetiapine for the long term. I think under the conditions, it would have been appropriate for her to be on quetiapine for a short period of time. But putting her on for a period of 2 years, which was the goal, was probably inappropriate. And I think it came about as a result of a misdiagnosis. I mentioned previously to you that she had traveled to Costa Rica when she was 15, and this was in 2017. And she didn't have any psychiatric symptoms, significant symptoms at all up until then. And I believe it was the last day of her trip that she said she started feeling strange. On the flight home, she started having delusions. She was imagining that the film on the flight was communicating with her, sending messages to her. She wasn't sure where she was. She was very disoriented and confused. When she returned home, I could see her dad and I could see that she was behaving very strangely. Her dad took her to the ER, and I met her there. They had already given her lorazepam, so she was out when I arrived at the hospital. And then they did run a tox screen and some blood tests, and they found that she had suffered a recent infection. Her blood test showed us that she had high levels of white blood cells. But they couldn't see anything that would explain her symptoms, so they presumed it was a psychiatric condition. She was mildly dehydrated, they saw, and she did have a rash, very significant rash on her face and chest and back. And that ended up giving us a clue what was really happening to her. But at the time we didn't really know. So she was admitted to a psychiatric department, and there they ran a battery of tests like a CAT scan and x-rays. And her psychiatrist just told us, that he thinks that it is first episode psychosis, and most likely related to either schizophrenia or mood disorder or schizoaffective disorder. And we would know more in the months to come as other symptoms would certainly follow. And that never happened.
Something I'm always interested in when people travel to Africa or South America and they get diagnosed with psychosis. Was she given any anti-malarials at all?
No. We think that because of her symptoms that later emerge, and she didn't have a memory, but she lost her memory, but after weeks, her memory came back and she could fill us in on more what was happening. And we took her to an infectious diseases specialist and described the symptoms and described where she had traveled. And there was an outbreak of chikungunya, which is a mosquito-borne virus. And she had traveled to parts of the country where she sustained lots of mosquito bites. And so we think that was and it's also highly correlative with psychiatric symptoms, including psychosis and delirium. And sometimes it can be pretty severe. And the course of treatment is typically put somebody on Seroquel for a couple of months. Mm-hmm. And then when symptoms resolve, then they take them off Seroquel. But that's not what her psychiatrists, in her case, decided. They dismissed the idea that she could have sustained a mosquito-borne virus. I said, even if she did, they reasoned if it were that would possibly trigger, this is exactly the words that he used, it would trigger an underlying defect in the brain, but it wouldn't cause psychosis. So the response was 2 years antipsychotics, minimal. And then I said, well, after that, can we take her off? And he said, in some cases, people do get off antipsychotics, but it's unusual. He said, I think that you will find that in the weeks and months that come, you will start to remember, as her parent, you will start to look back and remember that she had been exhibiting psychiatric symptoms up before this first episode. But that never happened. It really never happened. And I spent, I can't tell you how much time I spent reliving every conversation, talking to other people. Like, did you see anything? Looking at the photos from her trip to Costa Rica, examining her expression to see if there's any indication that something was going on. I never found anything.
Yeah.
But I didn't feel.
Well, I was just going to say, I'm glad we're talking about this, because this story really hits on something that a lot of people find. It's that there's seemingly little interest in the search for alternative explanations from psychiatrists when there's symptoms, right? You know, like you said, could this be an infectious cause? I mean, could it be a reaction to something else? I mean, we've got a normal person who's going to a different country, you know, and then, you know, subsequently exposed to things and then developing symptoms. It just, I think for most people would probably want their doctors to kind of look into more alternative explanations before saying, your daughter has a psychotic illness and there's a good chance she'll need meds for the rest of her life, which sounds kind of like what you were told. Yeah. And it's very hard to get that conclusion revisited at any point in the future. Yeah.
And it seemed like they were just looking for. So I did say at one point, when she was in middle school, she did have a lot of social anxiety. And so I saw in her record, they put social anxiety disorder, generalized anxiety disorder. She did resolve her symptoms pretty rapidly. I mean, they told me when she was in the hospital, we're going to ratchet up her medication slowly. And when I looked into Seroquel or quetiapine, you can't just immediately put somebody on, you know, therapeutic doses. You have to slowly increase it. She was on 25 milligrams and then 50 milligrams. I think she was on 25 milligrams for about 3 days, and there was no improvement. She was just still, I would go to the hospital and she was completely not there. She didn't make any sense at all. She would communicate, or she would say things like, I need to tell you something. And then she wouldn't say anything. I was like, what is it? What is it? And there would be nothing there. And then suddenly she'd say, you know, it's okay if you're gay or you're straight. It doesn't matter. So just random things like that. And then by day 4, she was rapidly improved. I thought she was improved. I could see it from a distance. As soon as I walked into the visiting room and I saw her there, I knew she was a lot better. She was making eye contact with me. She ran to me. She hugged me. And her first words were like, Mommy, why am I here? Why have you put me here? And she didn't have any idea what was going on. But at least I could talk to her. And she was saying, you know, what happened? And I explained to her. And then she would say things like, was there a war? No, there was no war. How long have I been here? Decades? How old I am? No, you're only 15. And at least she believed me. So by the end of that meeting, she felt a lot better, but she was completely despondent at the beginning of that meeting. And I could kind of understand why. One day you're in Costa Rica with your friends. The next day you're in a psychiatric department. She didn't have any idea how that happened. So I talked to her psychiatrist afterwards, and I'm like, she's a lot better. And he said, you know, I think she's depressed. And I was like, that's such a weird thing to say, you know. She's not depressed. She's just upset. Wouldn't you be? So in her records, it said depression, anxiety, depression. And so that became the explanation for her needing psychiatric medication. And he said, research shows that you need to be on Seroquel for 2 years to protect the brain. And I remember the gesture, protect the brain. I didn't find any research that supported that. But at the time, I just listened to him.
Mm-hmm. So walk us forward from there. Your daughter comes out of the hospital. She's better. She's on the Seroquel. What played out over the ensuing years?
Well, she remained on 50 milligrams. The inpatient psychiatrist said, you'll have to go to an outpatient psychiatrist, and it's really important that you continue ratcheting up until you get to therapeutic doses, like 200 milligrams, 300 milligrams to treat bipolar or schizophrenia, if that's what it is. But they didn't think it was schizophrenia because she never had any of the negative symptoms, but they thought most like it was bipolar or a mood disorder or schizoaffective disorder, something like that. Those were the terms they kept throwing out at me. I did find an outpatient psychiatrist, and I told the outpatient psychiatrist, look, she's on 50 milligrams right now. She seems to be doing fine. Why don't we just keep her at 50 milligrams of Seroquel? And the outpatient psychiatrist fortunately agreed. But still said we should keep her on for 2 years. I don't think 50 milligrams Seroquel would treat bipolar or schizophrenia or any kind of psychotic disorder. But she wasn't having any symptoms, so we decided just to keep her on there. And I would wait until 2 years, and then we would take her off. That was the plan. We didn't wait 2 years. It was not long after that she was really sleepy. She had such a hard time getting up in the morning. She was now a sophomore in high school, sleeping like 12, 14 hours a day, miserable, a kind of a zombie. So we cut her down to 25 milligrams, and she was fine. I think it was about 14 months. So it was like August of 2018, I think. And she traveled through Europe with her father, and they got delayed on the return trip. And her dad had an accident. It's a long story, but it delayed them, and they were about a day's drive from Belgrade. And they were kept up one night and then kept up another night. And so she didn't sleep for 3 or 4 nights and didn't take her medication. And then when she came home, she couldn't sleep at all. She didn't sleep for maybe 4 nights. And then she had a lot of anxiety. And at first I thought it was just jet lag, but I know now that was probably withdrawal from Seroquel, anxiety and sleeplessness. Her psychiatrist said, increase her dosage back up to 50 milligrams. And then as soon as we did that, she suffered catatonia. I mean, we hoped that she would sleep that night, and she still didn't. So now we're talking maybe 4 or 5 nights not sleeping. I don't know what that does to a person, not a 15-year-old, but it was, she was suffering. And I got to take her to the hospital. She couldn't even drink water. She was trying to. And I said, okay, if you're not able to drink water, I can't take care of you at home. She had just let you know, she had such a miserable time at the hospital that I promised her that unless you're like really seriously bad, like you can't take care of yourself or you're a danger to me or anyone else, that's the normal standard. But I thought, if you're not drinking water, I can't take care of you. So I took her to the hospital, and by the time I got her to the hospital, she wasn't talking, she was barely moving, and she was diagnosed with catatonia. The good news is that she didn't have to go into the psychiatric department with catatonia because they needed to give her an IV, and they don't have that type of facility in the psychiatric department. So I got to stay with her and watch her, but she just laid in bed for 3-4 days. And then finally they gave her benzodiazepine, and she got better. And it was almost like she wasn't sick at all. She got out of the hospital, and she didn't even realize how sick she was. At that point I thought, okay, maybe she really does need this medication. So it didn't occur to me then that it was the Seroquel that caused the catatonia.
So were you thinking it was something about her stopping the catatonia when she was stopping the Seroquel when she was traveling? Yeah,
I thought it was her underlying medical condition that had emerged. And at that point I thought, okay, they said it was a very unusual type of mood disorder that she had that would cause catatonia with very little warning. And I believed it. But then it just kept happening. So They got her while she was in the hospital. They ratcheted her up to maybe 75 milligrams. And then we slowly went back down to 25 milligrams. And then it was about a year later, she said, I have been stable on 25 milligrams for a year. I want to stop. So she stopped and she had a repeat. Same thing. She didn't sleep for 4 days.
Wow.
She didn't sleep for 4 days. She started having serious anxiety. And so we increased her and she still didn't sleep. And we increased her again. She still didn't sleep. And then she became catatonic. And they gave her benzodiazepines and she got better. I think it was maybe we decided that this was because she went from 25 milligrams to nothing. And to get off Seroquel, you have to taper down. So we went, at this point, she's now an adult. So we
Beth, just so I can jump in here, did the doctors tell you that, or was that something that you figured out on your own that she needed to taper from 25 to 0 more gradually?
Yeah, that was me. I thought that was what our mistake was, because I had read a lot about antipsychotics. I had read the works of, I don't have a psychiatric background. I don't have a medical background at all, but I did my best to learn everything. And I did some research, and there's a psychiatrist out of Canada. I think his name is Chouinard. Maybe you know his work, but he's done a lot of research on reducing from antipsychotics, especially quetiapine. And I learned he did work on supersensitivity, dopamine supersensitivity.
Yes.
And so I was really worried about that occurring, but that's not very likely when you have a very low dosage like what she was on.
How much guidance were you getting from your American doctors in Chicago in helping your daughter come off?
I didn't get any guidance on her coming off. As far as they were concerned, she needed to be on medication for the rest of her life. But I wasn't convinced. I wasn't convinced enough to keep her on the medication. I wasn't convinced enough to take her off. I had evidence. First of all, I didn't believe that a low dosage of quetiapine would treat the symptoms that she purported to have. Because you really do for schizophrenia or schizoaffective disorder or bipolar, you really 25, 75 milligrams of Seroquel shouldn't be enough. In most cases, maybe she's weird. That's possible. The other evidence is I was pretty convinced that she had a medical condition that caused her to have that first episode. Although it could have caused a permanent medical condition or a psychiatric condition. I don't know. Also, she had a therapist, and her therapist was not convinced because her therapist said her patients who suffer bipolar or schizoaffective disorder or schizophrenia, those are very difficult diseases to treat. And even if medicated, they're going to have breakthrough symptoms. And Anna didn't have any symptoms at all other than outside of those episodes.
Let's just stop there for a second, because I think that's really important to make clear because in the cases of I guess what we would call like the psychotic disorders like schizophrenia, schizoaffective, I guess what I'll call the true ones, where it's pretty clear to a lot of people that there's something going on. There's a lot of cognitive impairment that happens alongside the delusions and the hallucinations. You see a lot of that. But when you have these episodes of whether it's catatonia or psychosis, and then the person's returning to pretty good functioning, they're able to live their life, this kind of interact very normally. Sure, that can happen sometimes, but in many instances, that's a clue that we're not looking at, schizophrenia, schizoaffective, something like that, because it's not something that really looks fully normal in between episodes in a lot of the cases that I see. So I think that's interesting.
Yeah. Well, her psychiatrist was just like, well, she's lucky that the medication treats her so effectively that she doesn't have any symptoms when she's on the medication.
Yeah. And so walk us forward. Yeah. Walk us forward from here. So you're essentially being your own doctor for your daughter now. Maybe the doctors are going along with it, but you're doing the research. You've decided that maybe she needs to do a slower taper from 25 to 0. What happened next?
Well, she turned 18. So that meant that there aren't that many child psychiatrists that were available, but there's a lot of doctors who treat patients who are over 18. So that opened the door. And we did find a psychiatrist who's also a neuropsychiatrist. And I thought he'd be more open to the idea that she had a neuropsychiatric injury from an illness, from an infection. And he was. So we talked to him and told him the whole story. And I said, I think maybe we could figure out a way to reduce more slowly. And he agreed. And he said we could get a compound pharmacy to drop her to 20 milligrams. And so we tried that. And this is 2020, right at the beginning of the pandemic. And then it was the same, like maybe 3 days after being on 20 milligrams, she had the same symptoms. She would have no sleep, severe anxiety. And so when I called the doctor, I'm like, she's not sleeping at all. She's really anxious. And this is a person that doesn't normally have anxiety. I mean, she was diagnosed with a generalized anxiety disorder, but she's really not an anxious person. That she just had a little anxiety in middle school. So when she had anxiety, it was pretty obvious and it was weird. And the psychiatrist said, okay, well, we tried. It's clear that she has an underlying illness. So we need to go back up. So as soon as we went back up, she had a host of symptoms. She had akathisia, which I think is how you pronounce it, where she couldn't sit down. And then we kept going up, and then she had catatonia. And the psychiatrist, because we didn't want to hospitalize her because it was in the middle of COVID, he said, all right, I'll give you some benzodiazepines. Just give her benzodiazepines, and in a couple of days, she'll get out of the catatonia. And so we did, and she was better then. So he said, all right, let's keep her at 25 milligrams. I think it was maybe a year later. She took no, it wasn't even a year later. She took a prescriptive laxative, and it seemed to have blocked the absorption of her quetiapine. And she had another episode where she couldn't sleep, and she had anxiety. So the doctor then ratcheted up to 75 milligrams. And as soon as we did, she had catatonia. Wow. But he said, okay, that's because she skipped the medication, not because we ratcheted up the quetiapine. So he said, you're just going to, maybe someday you can get off it. But he's like, you know, since you had this episode, we need to keep you stable for a whole year before we go back down to maybe 50 or 25 milligrams. You're going to have to stay on 75 milligrams. She's now a freshman in college, and she's absolutely miserable at this dosage because she sleeps so much. And so she's just begging him, let me go back down to 50. And he said, you got to wait a year. So a year came, and he said, no, I don't think that's a good idea. I think you need to stay on 75 milligrams. And she was so demoralized. And she said, I'm going to go back down to 50. I can't function this way. And he said, if you do, you might end up becoming catatonic, and then we'll never be able to get you out. And so she took the chance, and she's an adult. She's like, I don't know what to do. And, you know, like, you're an adult. You have to make a decision. Do I think it's possible that you'll, end up permanently catatonic? Not really. I mean, as a parent, I want my child to be safe, but she's an adult, and I know what I would do in her situation, and I knew she was miserable. So I said, go ahead, do what you want. She goes back down to 50 milligrams, and she's absolutely loving life because she's able to function. She gets up in the morning. She's got a new job. She's back on campus. She's enjoying her classes. It's like, I can get up at 9 a.m. It's great, And then she takes some, she has a cough, and she takes some dextromethorphan, and she gets really sick, and she ends up in the ICU. And I believe she's treated for suspected serotonin syndrome. And she had a really high blood pressure, really high heart rate, and it was really scary. The doctors said, if her heart rate, if her blood pressure doesn't go down soon, she could be in serious trouble. And so she was in the ICU for like 3 days, and they stop the quetiapine at that point. And they give her benzodiazepine. She sleeps finally. And then she gets out of the hospital and she's fine. She goes back to campus, and her psychiatrist emails her. And all this time while she was in the ICU, I was trying to get a hold of her psychiatrist, and he's not responding. I'm pretty sure he's punishing her for making the decision to go from 75 to 50 against his advice. Mm-hmm. And she goes to her primary care physician. Her primary care physician says, I'll get in touch with your psychiatrist. Don't worry. He'll respond to me. So then he emails her and says, I've been informed of your hospitalization. Go back on 75 milligrams of quetiapine and stay there. And she does. So she restarts Seroquel because she had been off it for a few days. She restarts it. She goes back to 75 and she immediately becomes catatonic. I mean, not immediately, sorry. Mm-hmm. She immediately starts having insomnia and anxiety. We had just dropped her off at campus. We were on our way home and she's like, I haven't slept all night. Come and get me. So I'm like, okay. Oh, no. We bring her back home. She doesn't sleep for 3 or 4 days. And now she's not eating and she can't drink even. She tries though. She's not cognitively impaired. She knows what's going on. I can communicate with her, and she's distressed about not being able to sleep. She's distressed about her body not being normal. And how she can't swallow. She tries to swallow, but she winces. So, I take her to a different hospital. And at that hospital, they tell me.
I want to interrupt just because you're mentioning some things that are really interesting here. So the first comment I want to make is, the dextromethorphan plus the Seroquel, it's the two drugs together that can make someone have serotonin syndrome. So I think that's really interesting that because of the Seroquel, she was more likely to have that. Mm-hmm. And then the other thing that you mentioned, that would make me suspect is that Seroquel was probably never the right drug for your daughter, because it seems like she must have been especially sensitive to it. Because usually when someone develops serotonin syndrome, they'll be on 5 different serotonergic drugs, something like that. But with your daughter, just 2, cough medicine plus a low dose of Seroquel was enough to do it. So she was responding very strongly to the Seroquel. Yeah. And then the final thing was, if she's having difficulty swallowing when she's on the medication, one of the most common places that people can get movement disorders when they're on antipsychotics is in the esophagus. It can impair the ability of the esophagus to smoothly contract in a way that brings food down into the gut. And it sounds like that was what was happening to her if she was having a hard time. Yeah.
I've since, done some research more on how the function of that. And I believe that was, at the time I didn't make any significance. She also had incontinence. Mm-hmm. And she had difficulty managing her body temperature. So she'd be hot and cold. But keep in mind, all this time, she is not cognitively impaired. She's fully aware of the things that are happening in her body. So we take her to a different hospital. And I tell the ER, she's going to have catatonia. I could see at this point she was getting very close to having catatonia. I just need some benzodiazepines because I don't have a prescription for it, and we'll be fine. And this is at a different hospital. The ER doctor says, okay, you just came in here and you told me that your daughter is suffering catatonia. She hasn't eaten or slept in several days. I'm not just going to give you a prescription for benzodiazepines and send you on your merry way. I'm going to admit her, and she's going to see our psychiatrist. And that was just such a blessing. It really was. And the next day, the psychiatrist said, she's not suffering psychosis. This is delirium. By that time, she was pretty delirious. And we're going to stop the quetiapine. And that was October 4th, 2022. And she's not been on quetiapine since. They did put her on benzodiazepines. And, which, that benzodiazepines really does snap somebody out of catatonia. I mean, I'd see her. She was not moving at all, hardly. She could make eye contact and she could talk a little. She would move her lips, but she wasn't really vocalizing. She would kind of whisper or whimper. But then as soon as minutes after taking that, maybe 1 milligram of lorazepam, it's just like a veil lifted. And then she was just sitting there eating an apple, like nothing happened. So bizarre how quickly it is. Yeah. So she stopped the quetiapine. She was in the hospital. She put on a little bit of weight. You know, they made her drink some because she had lost a lot of weight. She's very thin. Mm-hmm. So not eating much for several days is really bad for her. And then I was a little concerned about her just stopping. She had been on 75 milligrams of quetiapine, and the doctor's like, she'll be fine. And then I reviewed the work of M. Chouinard, who is explaining that at that level, it's mostly just histamine, implicates histamine, and it will take maybe 6 weeks for somebody to have insomnia and anxiety, but dopamine is less implicated. So, and I think it was exactly 6 weeks before the anxiety stopped. And it was just like night and day. So she'd have severe anxiety and then and then it went away. And that was all that. So it was like anticlimactic how she stopped quetiapine, because I was expecting it to be such a hard thing, and we just did it.
Mm-hmm. Did she have any itching when she came off the quetiapine? Sometimes I've seen that.
Yeah, and she had her rash. But you know, the interesting thing is, since in the year and a half since she's been off quetiapine, overall her anxiety has gone down. She used to get so anxious when it came to school, and that's gone. She has a sense of humor. So her personality is so much easier going since being off quetiapine in general. And I think it's because, you know, if you're blocking histamine completely at 50, 75 milligrams, your brain's going to adapt. But then if you're not increasing your dosage, you're just going to have all this extra histamine, which is going to cause you to be anxious. That's what I think happened.
I mean, she was having, you know, right at the end when you kind of pieced it together the way you did, I mean, it was so lucky the doctor caught her when they did, because she had, I guess, what we call malignant catatonia, which is usually something where you would send someone to the ICU. It can get so bad, you know, you become confused. You get what they call autonomic dysfunction, which is the nervous system that we don't consciously control, that controls our heart rate and our temperature. So if she's getting hot and cold and it's happening randomly, then that nervous system has been compromised.
It can be fatal.
It can be fatal, exactly. And thank God that the doctor realized that was going on, because she's got all of these neurological problems. She's got the neuromuscular problems. She can't swallow anymore, and it's just a blessing that they caught it when they did. And I mean, the other thing with the story, which you've just hinted at, which I think is really interesting, was this drug was making her worse probably the whole time that she was on it, in subtle ways, with her anxiety and mood.
Mm-hmm. Yeah. So then it feels like, in a way, we jumped from the frying pan to the fire, because after we left the hospital, we followed up with a different outpatient psychiatrist who reviewed her whole records and totally agreed that she didn't need quetiapine. She didn't have a psychotic illness. It didn't have a mood disorder, and that the quetiapine was unnecessary. However, he didn't believe that quetiapine could cause catatonia. So he thought she had some sort of weird disorder that would cause catatonia. And he thought probably even the first episode was a type of catatonia. And he said, so I think she should be on benzodiazepines for at least 6 months. So, you know, we did. We kept her on benzodiazepines for 6 months. And in the beginning, he said, you know, you could, as long as it's 2 milligrams, I don't care if it's in the evening or during the day. But she was having difficulty sleeping. So I said, okay, here's what you could do. You could take 2 at night, but then during the day, when you have anxiety, let's just try and deal with it. Let's just like sit together and we'll talk. And, cause I didn't want her to start taking benzodiazepines for anxiety. And, but we went with the doctor and we said, okay, she will stay on it for 6 months, 2 milligrams at night. But then as soon as 6 months, if she's stable, we're going to start ratcheting down. And at this point, she's like so over psychiatrists, honestly. She doesn't even want to talk to any psychiatrist. She doesn't even want to go to the psychiatrist, and she doesn't want to take the meds at all. And I'm telling her, well, you've been through so much, and we don't really know why if that's true. That's what we think, but let's just give him a chance. And then in 6 months, sure enough, he said, actually, I think an argument could be made for her staying on benzodiazepines permanently, because catatonia is just so disruptive. So she's smart. She's doing science, biology in college, and but I don't have a science background. Anyway, we read a lot. We read about catatonia. We read The Madness of Fear, History of Catatonia by Drs. Fink and Shorter, I think. Mm-hmm. And they explain that a lot about catatonia. And according to them, if somebody is on antipsychotics and they suffer catatonia, the antipsychotics should be suspected as a possible cause. And they even group catatonia as a type of neuroleptic malignant syndrome. And they believe in this book that NMS, which is really associated with, the first generation antipsychotics, but it's usually associated with like overheating. But the overheating aspect is not really prevalent in second generation antipsychotics, but the catatonia is still there. And not only is antipsychotic, should it be considered a suspected cause? They argue in that book that antipsychotic should be stopped if somebody has catatonia. It could actually exacerbate catatonia. And benzodiazepines is the first line defense against catatonia, and that somebody should be on, even if they have an NMS, neuroleptic malignant syndrome, I think it is, they should be on benzodiazepines after they recover and for a period of time thereafter. But nowhere does it say 6 months or permanently, especially since she responds to catatonia, responds so quickly, like within minutes, she gets over catatonia. Yeah. So
that's some heavy reading that you've done there, because I know Max Fink's book, and I've read that one as well. And
for anybody who's had catatonia or knows somebody who's had catatonia, the book is really, really. I mean, he's also written textbooks, but this book is written for lay people, so I found it to be a really valuable resource. And I brought it to the psychiatrist, and I explained to him, like, this is what he says catatonia is about. And people don't just have it out of the blue. I mean, you can if you suffered a trauma, but there's not a disorder, called catatonia. It's associated with like a mood disorder, usually. Sure. Yeah. Anyway.
Well, the one thing I wanted to jump in about there was that I hope there's a happy end to this story. I suspect there is, but I do work with a lot of people currently with not a lot of people, a select few people with catatonia. And what you've said about the antipsychotics, what I see in my practice, because people come to me when they've been really hurt, is they'll have repeated episodes of catatonia, and the doctors, they'll just give them higher and higher amounts of antipsychotic instead of benzos, because there's such a stigma against benzodiazepine use. They go, I don't want to be involved in that. We'll just give them more and more Seroquel or more and more Zyprexa. And then they make them worse. And unfortunately, in some cases, one of the hardest things can be to wean someone off benzodiazepines, chronic long-term ones, when they have catatonia, which is what I'm doing now in a case. that's, if long-term benzodiazepines for catatonia, they just stop working eventually because people become tolerant to the medication, and then removing it just causes more catatonia. And so you end up in a situation where you have to rally the family together to essentially just watch someone be very catatonic while you bring the medications off. So it's dangerous. What the doctor told you to do is dangerous, because I've seen where that goes. And then really with benzodiazepines, once someone has responded to them initially, you can start tapering them down fairly quickly. And so, I'm eager to hear what happened with your daughter, because I'm just hoping that she didn't develop a terrible benzodiazepine dependency and get stuck on it. So please share the rest of that.
I think it would have been better if she stopped sooner. But I don't think she was on it. She's very disciplined. There's the tapering schedule. I think they use it in the UK, or you probably know about it. We found it online. It was a benzodiazepine tapering schedule by this doctor. Ashton Manual? That's it, the Ashton Manual.
Yeah.
She went to it was a psychiatric nurse practitioner who works in the clinic at her university, and basically just told the nurse, I want to get off benzodiazepines, and maybe I should switch to Valium, according to this. And the nurse said, no, because that has a longer half-life. So just stay on lorazepam or lorazepam, and slowly go down according to this. So she got down to 0.25 milligrams, which is very low, actually. And she just did it according to the schedule. But her psychiatrist, and she would have to continue going to the psychiatrist because they only give her, small amounts of medication at a time, and she needed the medication. But he was very unhappy with her. And he's like, you can't just drop down on your medication like that. But she was pretty committed to doing it, and she even provided him research to show that a prolonged schedule leads to worse outcomes. So she really knows what she's doing. And she found your content about doing dry tapers, because we did try, she would have migraines whenever she would step down from when she went from 70.75 milligrams to 50.5 milligrams. She would have migraines for a week. It was really disruptive. And then when she got to 0.25, she was like a half of a 0.5 tablet. She went to a psychiatrist here locally in Skokie who actually works with deprescribing patients who want to deprescribe benzodiazepines. And that psychiatrist suggested skipping a day. But that was really hard for her to do. So then she started doing a dry taper. And now she's on, I think, maybe 10% of a milligram. So 0.1 milligrams.
This is Ativan, right?
Yeah. So she weighs it. She's got a really sensitive scale, and then she takes a nail file and scrapes down a little bit.
She's pretty much there.
Maybe once a week.
That's great. That's great.
Yeah. So she is, so I think it's a happy ending. She knows, and it's hard for her to step down, and she's busy and she needs her sleep. And I tell her, don't rush through it. She's got plenty of medication to taper off, and she's doing really well. She's really happy.
If she made it that far without too much incident, I'm almost certain she's going to have a happy ending to this whole thing, as long as she just keeps on just chipping it down and doesn't rush it. I think she'll be just fine.
Yeah. I think it's a really low dosage in any event, so I'm not overly concerned. But it's a little bit of a shame that she just stayed on it for 2 milligrams a day for 6 months when it really wasn't necessary.
But that's,
a lot of this wasn't necessary.
It's like it's a big theme of the story, that there was a lot of unnecessary medication use for longer periods of time. And, long use of medication is obviously, now it's not benign. There's side effects, but also there's the longer you're on it for, the more tolerance you develop. And then it becomes much harder to remove something, after 6 months, as opposed to taking it away after 2 weeks. It's because it's really had its chance to have the brain kind of readapt to its presence and structurally change.
Right.
So, yeah.
But I do recognize that quetiapine causing catatonia is not very common. I did find some case reports where a man in his 40s, I think, who had a history of psychiatric medication, who was bipolar, and then he was given Seroquel as I think the word is adjuvant medication.
Mm-hmm.
And it was 25 milligrams, which is a low dose, and he immediately became catatonic. But in that case, they recognized that it was the Seroquel that caused the catatonia because, he had never had catatonia before. He was already in his 40s, and they just, immediately made that connection. And I think that the author's conclusion was this is either a rare phenomenon or it's rarely recognized.
Rarely recognized is what I would suspect, because the way we use antipsychotics these days is, we run into situations when someone will come in with either a psychotic or a bipolar illness, and they get put on an antipsychotic and maybe several other medications, and they develop side effects. And sometimes they'll develop akathisia, or they'll become more agitated. And then that becomes mistaken for the underlying condition, and it doesn't get recognized as side effects to the meds. And then so we have people who are already toxic, and then they give them higher and higher amounts, and we push people into NMS, or NMS with catatonia, the malignant catatonia. And I used to see that all the time when I was in the hospital, because I do think catatonia just on its own, when it doesn't come, from the medication side effects, is quite uncommon. In fact, I can't remember the last time I've seen it, if I've ever even seen it that way. But I remember hundreds of cases of people developing catatonia after being ratcheted up on lots of antipsychotics or taking dual antipsychotics at the same time. People are going to watch this right now. Did this happen to you? If something like this happened to you, could you please type up a brief story in the comments below? Because I've heard 3 of these stories in the last year of catatonia. Just one that's come on the channel, but I also have people reach out to me and people that I work with now. And so I actually don't think it's that uncommon for people to get stuck where your daughter was. Yeah.
I also wanted to mention that with Anna, she didn't have the kind of catatonia that you would see in like that movie Awakenings, if you recall, where she was just vacant and just stiff. She did have some movement. It was just very slow. And she couldn't really talk, but she tried to, and she could make eye contact, but that's catatonia.
Mm-hmm. Yeah, the ones that I've seen recently have not been frozen. They've been, they may kind of make strange postures at times. They'll kind of almost like a statue, or they'll kind of stand in funny ways, and they'll become very excitable sometimes. Yeah, and then they'll make like facial expressions. It's really quite distinctive.
Yeah. Now, would that be associated with antipsychotic use, or maybe because the patient was bipolar or had some other kind of trauma?
I mean, the one I'm thinking of is probably, it's hard to tell what it's associated with, but it's not associated with recently being on lots of antipsychotics. But catatonia can present in a lot of different ways. Yeah. Yeah.
I think, if I recall from the book Madness of Fear, there's the presentation is slightly different. There could be overlap. It's not a bright line, but there's going to be typically a little slightly different presentation between somebody who's suffering neuroleptic-induced catatonia and then another type of more general catatonia. And I think, what Anna was doing was much more just met the description that he used to describe neuroleptic-induced catatonia.
What a great book. So
yeah,
so
helpful for me.
What was this whole thing like for you? Tell us about that.
I was always just hopeful that she would one day not be on medication. I mean, I think from the very beginning, it was quite a shock I really feel for parents who have a child who has a serious mental health issue. And I feel very, very fortunate that my child was able to overcome it, or that it wasn't actually what was going on. But I have a responsibility to this child to make decisions for her that aren't necessarily aligned with my agenda, but for her agenda. So my agenda would be to be cautious and err on the side of caution. But I also had to think, what would I want my parent to do for me? And maybe if it were me, I wouldn't take the medication. I would just tell them, no way, I'm not going to take, all these medications for 2 years. I'm feeling fine. So it was really an ethical dilemma for a parent to have to make these decisions. You have to really consider not just your own desires to keep your child safe, and overcome that. Because I want her to have a full life as well as be safe.
I mean, one thing that you didn't touch on, which I think is interesting, is you had that feeling that, hey, maybe she shouldn't be on this that long. How did your husband feel about the whole thing? Were you both aligned, or was it split?
So her dad and I are divorced, but we're still really close. Okay. And he was much more, I don't think he recognized the downside of being on these medications. And I think it was the second or third the final hospitalization, he was telling her, you just need to stay on these medications. So what? And I told him, you need to understand this. And I explained how medications over time become less effective. And then, this is going to be a constant battle that's going to be lifelong, and we don't even know if she really needs them. And when the psychiatrist came in and said, she doesn't have a psychiatric illness. He said, she doesn't have a psychotic illness. If she did, this is not psychosis. This is delirium from a medication change. I'm in this hospital. I treat it every day. And I felt so vindicated. I said to her, see, this is what I've been telling you. And he was really glad, that she made a recovery. But I did get a lot of pushback from extended family and them telling her, look, your mother cares for you, but she is not a psychiatrist. You can't just listen to her. And it was more to appease them that I would continue to find psychiatrists. And that's why we went to a psychiatrist in December, just to get that validation. And then I said, see, we found a psychiatrist who sees things the way we see it. It puts mothers just like you and other people in similar situations in such difficult positions because, where we automatically want to believe the authority figures out there, and when someone has a white coat and an MD and all of that, who am I? That's what a lot of people think. Who am I to question what this expert does? And for a lot of things, that's the right way to go about it because, how are you going to know these things? But in situations like this, where the mental health care, especially in the US, is so rushed and so poor, and they don't really pay attention to really understanding things, and maybe they practice in a way which is with self-interest in some ways because, it's going to look like I'm more cautious if I put her on the drug for 2 years. There's going to be less chance of, rocky waters if I, maybe try and bring her off sooner. That there's this kind of sense of self-preservation. If I just put them on the drug a little bit more, I'm especially cautious. And it pits family members against one another, because they're like, well, I'm just going to listen to the doctor. It's so difficult. Yeah. so I did want to make another comment. I feel like in some ways the original psychiatrist acted with a level of hubris that, I don't appreciate, because he just dismissed a lot of the comments that I made when I said, isn't it odd that she would just have a sudden episode and then it would come out? And he's like, no, that's not odd at all. That's kind of unforgivable, and I'm resentful towards that. However, so I don't have a background in mental health or science, but I do have a background in law, and I was a lawyer, and then I became a journalist, and I currently work in a field where I document medical malpractice cases for the insurance industry and for the litigation industry. And I have access to all the medical malpractice cases there are. And psychiatrists do get sued a lot. And I'm not saying it's lawyers' fault. I'm not saying, we medicate, not because there are a lot of factors at play here. Like there's a pharmaceutical and, for-profit pharmaceutical industry, and, medical practices are for-profit, and then lawyers are for-profit, and insurance companies are for-profit. But most of the psychiatry time, most of the cases that I've seen where psychiatrists are sued for a lot of money is when a patient completes suicide. And I've seen cases where the doctor would be able to document, we asked him when he was in the hospital, before he left the hospital, are you thinking of harming yourself? And I know that they get asked. Anna made a joke at one point to her doctor when she was asked if she's thinking of harming herself. And she said, I will if you keep asking me this question. And I said, no, you can't make that joke. They have to take that seriously. But doctors get sued for that. They don't get sued for, I can think of 5 cases where a doctor got sued for under-medicating or for over-medicating. Most 95% of the time, they're getting sued for under-medicating. Okay, you gave him this medication. You should have given him another medication. Or you should have given him more medication. You gave him 3 medications. You should have given him 4. You should have done something to prevent his suicide. And you're at fault for that.
Yeah, and there's what I will say as well, and this will resonate with anyone who works in an industry where there are norms, is that there's a tremendous amount of peer pressure as well. We want to practice in alignment with our peers, and unfortunately in the US and in a lot of other Western worlds, it is very medication heavy, and some of these guidelines are really not in the best interest of patients. And so when they practice, they go, oh, maybe I could do a taper, but I've read this guideline that says after a psychotic episode, there needs to be 2 years. I've never seen that guideline, but I guess that person had. And so I think there's just this pressure that doctors feel where they say, I just need to practice completely in alignment. And that's usually just to give more medications and to interpret additional signs and symptoms as further psychiatric illness.
Right. And if you do get sued, in order to file a lawsuit, a patient has to get another doctor to file a statement saying, yes, this doctor breached the standard of care. And so what is the standard of care? It's really hard to quantify. It's easy to quantify if it's just a matter of did you give him enough medication? But, in the case of Anna, she's not going to be able to sue because, she came in, her records show that she had psychosis and she had generalized anxiety disorder. And, was it a mistake? Probably. Yeah, it was a misdiagnosis for sure, but you can't sue for that. Because, there's no standard that says, you don't medicate for somebody who has psychosis. It's the opposite. So, I don't have resentment for the industry in general, but I think it's dangerous. And I think that, my child got lucky. Just coincidence. She found a psychiatrist that was able to take a closer look and not just rely on, stare decisis, what some other doctor had decided.
Yeah. Well, thank you so much for coming on and sharing your story. Do you have any parting comments before we wrap up?
No, but I think that was the parting comment I wanted to make, is that we can't blame doctors. I think we have to, at some point, we have to blame ourselves, or take some, as consumers of healthcare, we have to take some responsibility of what we expect. We can't expect doctors to fix everything for us. And then if there are psychiatrists who are willing to, step outside of their safety zone and write statements, and so doctors can get sued for over medicating, and so that they have to then make a more balanced or nuanced decision, that might help the industry a little.
That will definitely help. Well, Beth, thank you so much for coming on and sharing your story.
Yeah, one other, if I can, I do have, of course, so much empathy and compassion for the families who are suffering from have family members who suffer from a serious mental illness, and I hope I never sounded glib. No. I'm grateful that my child is recovered. So thank you.
Thanks.